Welcome to this edition of Buddhi Insight. Today we're discussing behavior and the aging brain, and this is a conversation on the behavioral and psychological symptoms of dementia and what actually helps. A woman called me not so long ago. Her father is 81, and 2 years earlier he'd been diagnosed with mild memory loss. Nothing dramatic, the kind of forgetting that the family learns almost without noticing to work around. She was calling because her father had looked at her mother, his wife of 52 years, and told her that she was an impostor. He hadn't slept properly in 4 nights, and one night he tried to leave the house at 2 in the morning, convinced that he had a train to catch. 2 days before she rang me, when she tried to gently stop him, he pushed her. The family didn't come to us because of memory loss. They came to us in a crisis because of the person's behavior. I've sat with versions of the story more times than I can count over 3 decades of practice. Many of you listening have lived some version of it too, quietly, often carrying a little shame about it, as if it reflects badly on the family rather than on the illness. So that's what I'd like to talk to you about today. How common this really is, why it matters, sometimes more than memory loss, and that's what gets all the public attention. And we need to also talk about what genuinely helps, which medicines have earned their place, which therapies have real evidence behind them, and where technology is proving itself rather than being just marketed to us. I'd rather be useful to you than reassuring. Let's begin. In neuropsychiatry, we have a name for this cluster of symptoms, BPSD, the behavioral and psychological symptoms of dementia. It's a clumsy acronym for something very large: agitation, aggression, apathy, wandering, disturbed sleep, delusions, hallucinations, depression, anxiety, disinhibition, repetitive speech or movement. All of these constitute BPSD, or behavioral and psychological symptoms of dementia. Now, notice how this list is long and yet has nothing to do with forgetting. What's happened is that we've allowed dementia to be marketed almost entirely as a memory disease: misplaced keys, forgotten names. But if you talk to a family that's actually lived through it, or any clinician who's actually treated it, you'll hear the same thing. Memory loss is rarely what breaks a household. And it's wandering at 2 in the morning, the accusation of theft aimed at a devoted daughter in law, the sudden aggression in a man who was gentle in his whole life, the apathy that quietly empties a once vibrant woman of herself. These are the things that people complain about. These are the things that people worry about. And very often, these are the things that take them to the doctor, bring them to people like me. Now, I've spent a lot of my working life on this particular interface, and I've started to call this a neurobehavioral disability, a place where brain dysfunction and behavior meet. In delirium, in stroke, in Parkinson's disease, in traumatic brain injury, or in dementia, the story is pretty much the same. Behavior is data, often the only language that the brain has left to tell us that something is wrong. Let me start by sharing some numbers, because most people, myself included when I started working in this area, underestimate just how common these problems are. Globally, more than 57 million people are living with dementia today. That's an astounding figure put out by the World Health Organization. And nearly 10 million new cases are diagnosed every year. In India, the prevalence is between 6 and 8% in people over the age of 60, and that is roughly 8.8 million people living with dementia. More than 60% of everyone living with dementia worldwide is in a low or middle income country like ours, where the infrastructure for caregiving is the thinnest. A systematic review and meta-analysis that was published in the journal Age and Aging in 2025, looking at older adults with dementia in acute hospitals, found that 60% that means more than 6 out of 10, showed at least one behavioral or psychological symptom. And this is a conservative hospital based estimate. Longer studies following people with Alzheimer's disease over time found that 90% will experience at least one significant symptom at some point. Not most, essentially everyone will have a behavioral and psychological symptom at some point of time during their journey with dementia. And I need to tell you something very, very interesting. This is part of a PhD that one of my students has been doing and has just completed recently. One BPSD, one symptom is enough to be disabling. Now, this is a very, very important factor. We don't need multiple symptoms. Just one symptom will do in order to be a tremendous source of problem to the patient or the family or both. Now, of these symptoms, agitation and aggression affect close to 39% of people with dementia. Sleep disturbances, about 38%. Problems with eating, 36%. Irritability, roughly a third. And apathy, being quiet, being unwilling to engage with the world, very easy to miss, if often thought as just giving up. About a third of patients still at home. And that really makes it the most under-recognized symptom in the entire spectrum of symptoms that we've been talking about. Thus, if dementia is a house fire, BPSD is not smoke curling from one window. It is the fire itself. There's a part of this story I wish got more attention, even within my own profession. For a long time, we thought of behavioral symptoms as something that arrives after the diagnosis, a complication of dementia once it's already established. We now understand that this is often the wrong way around. There's a well validated idea in our field. It's called mild behavioral impairment, or MBI. It describes the appearance later in life of persistent changes in mood, motivation, impulse control, social behavior, or perception in someone whose cognitive testing still looks essentially normal. Research on MBI, which has grown substantially over the last decade, tells us these changes can appear years before any measurable decline in memory. So, some years ago, we became familiar with the concept of MCI, or mild cognitive impairment, and we call it the pre-dementing stage. Now, absorb this. We also have mild behavioral impairment, which can precede the onset of dementia rather than follow it. And very often, these may be symptoms that we mistake for just an older person becoming eccentric or erratic. We don't realize they are the harbingers of something much more serious that is bound to follow. So, a man who has been even tempered in his whole life becomes persistently irritable for no reason at all. A meticulous woman develops an uncharacteristic apathy at 70, well before anyone notices that she's repeating herself. These are not simply the quirks of growing older. They are often the earliest visible sign of a neurodegenerative process that has not yet shown up on a memory test, or indeed, no one's thought about doing a memory test for this person. That reframes the whole conversation. BPSD isn't only something we manage once dementia is advanced, it can be an early warning. In some patients, arguably a more sensitive one than the cognitive tests we've relied on for decades. And please understand, therefore, that behavioral symptoms are to be taken seriously when they manifest in an elder and are different from the way this person usually has been in the past. Now, how does that happen biologically? The circuits that govern mood, motivation, and impulse control, your frontal lobes, the basal ganglia, which are also responsible for movement, the limbic system, which we often talk about, which is the hothouse of all emotion, and neurotransmitters like dopamine, serotonin, and acetylcholine are often touched by the same degenerative process that will later erode memory. Behavior changes first because those circuits sit closer to the surface than the memory circuits that we are more used to testing. BPSD matters therefore enormously on its own terms, quite apart from what it predicts. It is, in my experience, the single strongest driver of caregiver exhaustion. The data on dementia caregiving in India consistently shows moderate to severe burden, and what caregivers describe to doctors like me isn't tiredness from repeating the day's date. It's the particular exhaustion of being accused, sometimes struck, sometimes simply not recognized by someone they love deeply. And indeed, if you think about it, one of the biggest challenges of caregiving for dementia is not the caregiving itself. It is that the person you're caregiving for has no way of knowing the value and importance of what you are doing for them. So, when you caregive for someone with another form of disability, with cancer, for example, or after a road traffic accident, for example, the person recognizes what you are doing for them. The person with dementia has no way, unfortunately, of even knowing the value of what is being done by the caregiver. And BPSD, therefore, becomes one of the common reasons why families end up in hospital. It's the most common reason for early institutionalization. And it's a contributor, unfortunately, to excess mortality when it is handled badly. Left untreated, agitation and psychosis erode a person's dignity as much as loss of memory on its own does. Common, often an early signal, it's one of the most disabling parts of the entire dementia journey. Before we get to medicines, before technology, there is a sequence worth understanding. Getting this right matters more than any single treatment decision. So let's talk now about what actually helps. The framework most of us in this field rely on is called DICE: describe, investigate, create, evaluate. You describe the behavior as precisely as you can. You investigate what might be driving it. It could be pain, it could be a urinary infection, it could be poor sleep, it could be an overstimulating room, it could be a caregiver who's at the end of their tether, the end of their patience. You then create a plan that is suited to this person, and usually that plan starts without medication. You then evaluate honestly and adjust. For example, when someone, an elder particularly, in a hospital room is getting really agitated or aggressive or confused, one of the first things we do is open the window, let the light in, orient the person to what time of the day it is, where they are. People find this tremendously reassuring. When you are confused and disoriented, your vision and hearing are impaired, as is often the case for an elder. Somebody creeping up next to them without telling them who they are can be terribly frightening. A behavior is often a response to something as simple as that. And I think this is something that we all need to understand. A great deal of what is reflexively labeled as BPSD and treated with a sedative is often undiagnosed infection, undertreated pain, or a delirium that is layered on top of the underlying dementia. And this is extraordinarily common. Delirium states, which are confusional states, complicate about 30% of hospital admissions in older adults. And very often, treating the medical cause resolves the behavior far more often than treating the behavior on its own. Describe and investigate is therefore important almost always before reaching for a prescription. There's a broad consensus now in geriatric psychiatry. The American Geriatric Society says this plainly, that non drug approaches should be the first line of treatment for PBSD, not something we turn to only when medication has failed. So, what actually works? Caregiver training, in my experience, has the strongest and most consistent evidence of anything in this list. Simply teaching families how to communicate differently, how to step back from confrontation, how to redirect rather than correct, changes outcomes more reliably than almost any drug that I can prescribe. It's core treatment and not a soft optional extra. Individualized approaches, understanding one specific behavior in one specific person and its specific triggers, consistently do better than generic protocols applied the same way to everyone. For example, we had an elder whose delusion centered around two specific helpers in the home. He was perfectly well when those helpers were not around. Yet, when those helpers came into the room, he would start exhibiting aggressive or disturbed behavior. Unfortunately for the family, they could not change the helpers for a range of other reasons, including other sick people in the home. And therefore, we had to find a way of limiting his exposure to those helpers. And this is precisely the kind of information that we seek when we try to modulate the environment to ensure that behavioral symptoms do not manifest. Cognitive stimulation and structured activity reduce agitation and lift mood, particularly when the activity connects to something in the person actually valued before their illness. It could be their work, their faith, their music, their garden. For one of our patients, it's old Hindi music, and it also is his collection of lithographs and photographs and watches and clocks. Now, these the person connects to, and the therapist working with them finds it extraordinarily easy to bring attention back to those objects as part of cognitive retraining. Rather than ask a generic question, talking about a favorite item like a photograph or a clock and asking where did this come from or when was this taken or who helped you acquire this makes it so much more engaging for the person with cognitive impairment and dementia. And this we call reminiscence work. It shows real benefit for mood in a number of trials. Validation therapy, which is meeting someone in their emotional truth rather than correcting their facts, has a more mixed record. Some studies find real benefit, others don't replicate it. This field is sometimes sold with more certainty than the evidence supports. I talked about opening the windows, changes to light and noise, orientation cues, safety that doesn't tip into restriction, music, structured physical activity. These turn up again and again in the better quality studies that we are exposed to. In fact, one Eastern form of therapy that seems to work very well for older people with cognitive impairment is Tai Chi. And Tai Chi, as you know, is slow rhythmic movement. It has impact on cognition, it has impact on mental health, and it also has impact on posture and balance, all of which are crucial for the aging brain. Behavior is a form of communication. Understand, therefore, what this person is trying to tell you. Don't silence it, is something that we always advise patients' families. Now, with medication, I'd like to be as candid as possible with you, even though this is a public conversation. Cholinesterase inhibitors, donepezil and rivastigmine, are both available in India and have been so for more than a decade. They are extensively used. And then, of course, we have an NMDA receptor drug, memantine. All of these were developed to slow the cognitive decline in Alzheimer's disease, but they carry a useful secondary benefit. On their own, they can reduce the behavioral symptoms too. So, started early, they are often my first choice because they work on both cognition and behavior together. One caution is that stopping them suddenly often brings the symptoms back, and therefore withdrawal needs to be planned and not casual. Antidepressants, especially SSRIs, serotonin reuptake inhibitors, genuinely help with the depression and anxiety that is often associated with neurodegeneration. And most often, they are fairly well tolerated in older patients. Then there are antipsychotics and or what we call neuroleptics, and I want to speak with these about with a little bit of care because Public conversation about these drugs can swing between two unhelpful extremes. Some call them poison, others say they are harmless. Neither is quite true. Twice in 2005 and later in 2008, the FDA of the American, the Federal Drug Administration has placed a black box warning on these medicines for dementia related psychosis and agitation because they seem to cause mortality risk. They increase the chance of mortality by 1.5 to 1.75 times when compared to the placebo. Mostly, they seem to cause cardiovascular events and pneumonia. That warning is real. But then there is a clinical reality that we sit with every week, something that most caregivers will recognize. In India, the alternative to medication for people suffering with BPS is rarely a well staffed, dementia trained care facility. More often, it is the family, alone, at 2 in the morning, with someone they love who is frightened, agitated, sometimes aggressive, and whom they cannot safely manage. So, when behavior threatens the safety of the patient, the caregiver, or the very possibility of remaining at home, it becomes the reason why they end up in a care facility or they end up getting admitted in hospital. A prudent, well monitored medication is not failure of good care. It often becomes the precise reason the family is able to go on caregiving for the individual. And therefore, antipsychotics are never the first thing to reach for, and they can never be instituted without working through these non drug approaches that we've been talking about. But when home care is genuinely at risk of collapsing, a prudent, well monitored use is a legitimate clinical choice and not a lapse in one. In practice, with any of these drugs, the lowest dose that works for the shortest time necessary, with real repeated attempts to taper, and a family working with one that understands the trade off, because uncontrolled agitation, an exhausted caregiver, and forced institutional placement all carry serious risks of their own. So, my rules with most drugs for older people are start at half or sometimes a third of the usual adult dose. An aging or already damaged brain is a more sensitive brain. Introduce one medication at a time, change one medicine at a time. If you can, choose one medicine that can tackle two problems at once. To give you an example, an anti epileptic drug can protect both against seizures and stabilize mood and behavior. Therefore, it can be used for both purposes rather than one drug for epilepsy and one drug for behavior. And then avoid stacking two drugs from the same family without good reason. Two antipsychotics, two serotonin drugs, best avoided in older people. What's most important is a genuine therapeutic alliance. Doctor, patient, and caregiver in honest, ongoing conversation about benefit, risk, and the patient's own right to decline treatment wherever that can be safely honored. Medicines are legitimate, sometimes essential, including the antipsychotic that lets someone stay safely at home, never the first or only part. Now, let's talk about technology, which is a field I've worked for in over a decade, and one where I'd rather tell you what we actually do in clinic than what belongs to a research paper or a brochure. We now have digital tools that can pick up the earliest changes in a single person's cognition, track functional decline over time, and through wearables, quietly monitor gait, sleep, and physiological patterns that correlate with mood and behavior, often before a family or even a clinician would notice anything in conversation. If behavior changes before memory does, our diagnostic tools need to catch behavior changing too. Then, of course, there is neuromodulation, where I think the real discipline about evidence matters. And I'd like to tell you specifically what we do in Buddhi Clinic and why. The most important treatment that we use in older people is transcranial direct current stimulation. Now, the early studies were small exploratory work asking whether a weak current applied to the scalp could modulate cortical excitability and improve cognition in Alzheimer's disease and mild cognitive impairment. The foundational, basic, and early clinical research suggested it could enhance synaptic plasticity and even reduce amyloid beta pathology. Our TDCS protocol follows the design published by Linda Lam and her colleagues from the Chinese University of Hong Kong. Direct current stimulation paired with structured memory training delivered daily over several weeks. In their trial of 201 older adults with mild cognitive disorder due to Alzheimer's disease, this combination produced greater gains than either the stimulation or the training could achieve alone. Now, we need to be precise about the status of TDCS. It remains an active area of research. It is not yet standard clinical treatment, and there are trials that shows it improves global cognition in Alzheimer's disease and produces clinically meaningful cognitive gains in a subset of patients. In others, it does not, and therefore the results are genuinely mixed. Where the field is moving towards is personalization, using an individual's own brain connectivity to guide where the current goes, and combining stimulation with cognitive training and electrophysiological monitoring so that we can both improve the outcome and actually measure it. That is the direction we have tried to follow in our protocol. We've taken that a step further, layering in normobaric oxygen therapy alongside the stimulation. And this is not a decorative addition. Oxygen driven neuroplasticity has published support in stroke and traumatic brain injury recovery. And we are applying the same principles here, essentially priming the tissue the current is trying to influence with NBOT applied in a 5 liter per minute flow. 5 liters a minute of normobaric oxygen delivered alongside the stimulation session rather than separately from it is what we do. And I mention that deliberately. Oxygen therapy is not a protocol, a defined flow, a defined duration, and a defined relationship to the current. That is what makes it something you can replicate, audit, and eventually test. This combined approach moves memory and behavior in the same person at the same time. RTMS, or repetitive transcranial magnetic stimulation, is well established. It's also non invasive, it's painless, it requires no anesthesia, and the evidence for its use in dementia continues to grow, with patients who have more education and milder disease tending to respond better. Timing seems to matter very much with RTMS, earlier being better. Pooling the trials, higher frequency RTMS produces a significant improvement in cognition on the ADAS cog when compared with sham RTMS. Sham RTMS is when you appear to give an RTMS session, but the person is not really receiving the electromagnetic stimulation. The effects tend to be more robust and more durable when the RTMS is paired with structured cognitive training rather than delivered on its own. So notice the commonality here, both with TDCS and with RTMS. It is not just delivering the stimulation that matters, it is giving it along with the human interface of structured cognitive therapy. So it's so important to work with people on their cognition, on their mood, on their behavior while stimulating them with these new technologies. Agitation, apathy, and depression are the triad that most complicates day to day dementia care. And conventional pharmacology, cholinesterase inhibitors, and antipsychotics all appear to offer limited benefit. Against that backdrop, RTMS shows a moderate overall benefit for these symptoms. That positions it as a unique adjunct rather than as a last resort, particularly relevant given that antipsychotics carry FDA box warnings for increased mortality in dementia. Now, which symptom response depends heavily on where the coil sits. Protocols focused on the dorsolateral prefrontal cortex, which is the front of the brain, dominate the mood and apathy literature, while parietal and precuneus targeted protocols track more closely with memory network decline. It is the same symptom to substrate logic that shaped our own precuneus work in Alzheimer's disease. Where we pushed it a little further is on precisely where we stimulate. We've been among the first in India to bring precuneus targeted RTMS into clinical use for Alzheimer's disease. The precuneus itself sits in the center of the brain's default mode network and is closely tied to episodic memory, and it's one of the earliest regions to show metabolic decline in this illness. Published sham controlled trials targeting it have shown measurable gains in episodic memory and default mode network activity. And a year long extension found it slowed not only cognitive decline but the progression of behavioral disturbance and loss of independence. Our own early patients on this protocol have done well, and I want to be careful here to say that it's a small growing series in our hands, not a completed trial of our own, but promising enough that we've made it part of our standard offering for those in whom it seems to be the suitable approach. Other technologies that we can use in dementia care are vagus nerve stimulation. The auricular branch of the vagus is what we stimulate, and neurofeedback guided by QEEG, especially in milder patients and well educated patients who are seeking cognitive stimulation. These are still newer in our experience, earlier in their evidence, but they are grounded in sound rationale and worth watching closely rather than dismissing or overselling. Let's be aware, no device is available that reverses dementia. None does. That's very important for us to know. But what the honest evidence shows, including our own data, is that it's exciting. The technology that catches decline earlier and technology, when layered into good medical and psychological care, measurably improves outcome for a meaningful number of patients. I want to close this part with all of what this looks like in practice. I've come to believe that integration, not any single therapy on its own, is the real answer here. At Buddhi Clinic, over roughly the last decade, we've worked on more than 15,000 patients across 26 Indian states and 22 countries, delivering 520,000 therapy sessions, including more than 41,000 sessions of non invasive brain stimulation. So it's a very large number of sessions for a very large number of people that we have worked with. That scale has let us track our outcomes systematically rather than rely on impression alone. In one structured program for Alzheimer's dementia, combining assessment, guided integrative therapy with targeted brain stimulation, we watched cognitive scores on the Addenbrooke cognitive examination rise from an average of 62 out of 100 to 73 out of 100, and that gain held at 24 months, not just at the end of treatment. In a separate group of 50 patients, 73% showed measurable improvement on the mini mental state examination within 8 weeks, alongside meaningful reductions on the neuropsychiatric inventory, which is what we use to track the behavioral and psychological symptoms. Integrative therapy using holistic approaches from Ayurveda, naturopathy, and yoga combined with TDCS produced a larger gain than integrative therapy alone. Evidence in our numbers for the layering principle rather than any single silver bullet. None of this, of course, replaces good pharmacology or good psychiatry or good family support. It sits on top of them. Our team brings together neurologists, psychiatrists, neuropsychologists, therapists, and quite deliberately practitioners of local, culturally rooted traditions, all working from one coordinated plan for one patient. A team willing to describe carefully, investigate honestly, and evaluate without ego. That's what actually changes outcomes, in my view. If you're listening because someone you love has begun to act differently, here's what I'd ask you to do. Don't assume it's simply old age. Don't assume it's simply dementia either. New agitation, withdrawal, suspicion, or sleep disruption in an older adult deserves a proper medical look. Rule out infection, pain, medication side effects, and depression before anything else. If a diagnosis of dementia is already in place, understand that the behavioral symptoms are not a footnote to the illness. In my experience, they are often what determine someone's quality of life, and yours as the caregiver, far more than the memory loss does. Ask for non drug approaches first. Ask for caregiver training for yourself. It remains genuinely the single most evidence backed thing we have to offer as a profession. If an antipsychotic or a neuroleptic becomes necessary to keep someone safely at home, that can be the right decision, not a failure of one. But ask about the black box warning, ask about what's being tried, ask for the lowest dose that works, and ask about the plan for tapering it, not only for starting it. Ask what technology, if any, genuinely suits this person at this stage, and be just skeptical of anyone promising a cure as you are of anyone insisting that technology can never help. Look after that caregiver. That isn't just a sentiment, it's a clinical fact. The family I told you about at the start of this talk, the father who no longer recognized his wife for 52 years, is, I'm glad to say, doing much better today. Not just because of a miracle drug, because we took the time to describe precisely what was happening, investigate what was driving it, build a plan that combined a modest, carefully judged change in medication with caregiver coaching and a steady daily routine, and kept evaluating and adjusting until it worked. Behavior is information. It deserves the same rigor as any other serious medical symptom. This is Dr. E.S. Krishnamurthy of and for Buddhi Clinic. Thank you for listening.